Okay, stop the guessing game. Implementing a criterion and evidence-based functional performance testing algorithm for the foot and ankle following musculoskeletal related injuries. This is a portion of a larger presentation. We will talk about the range of motion, the dynamic postural control assessment, as well as muscle performance criteria when determining someone's readiness to return to activity and return to sport following foot and ankle injuries. Learning objectives of today are analyzing the importance of functional testing algorithms for determining return to sport and return to function readiness in patients following musculoskeletal related foot and ankle injuries, evaluating the evidence on the appropriate use of physical performance tests to determine readiness for return to function post foot and ankle injuries, develop a criterion-based, algorithmic, and evidence-based approach to determining readiness and clearance for return to jogging, plyometrics, and higher level activities, and synthesizing practical recommendations for implementing return to function physical performance test algorithms for the foot and ankle complex in clinical practice, taking into account the patient's demographic, functional capacity, and the specific pathology that they're recovering from. As I alluded to, this is part of a larger presentation that is multi-part in nature. Today's section will focus on number 4, the range of motion, postural control, and the muscle performance capacities. My greater purpose in giving today's presentation is to present new ideas, concepts, principles, and resources that maybe you are otherwise thinking of and or that are novel to you. My hopes is that this spawns new questions, sparks internal controversy and critical thinking and brainstorming of new and novel ideas for your own clinical practice, give rise to new ideas and new aspirations and inspiration for your clinical practice that will change your day-to-day on Monday, and that together on the hopes that we can raise and elevate the profession on the whole, giving a better standard of care across our profession. That being said, my secondary goal is to avoid something such as this. So if it's not me, then perhaps it's the coffee that you're drinking that will keep you awake as we go through the remainder of today's presentation. As I alluded to, here's the roadmap of the presentation on the whole. The section that I will be focusing on will be foot and ankle mobility, postural and dynamic control, and then the assessment of strength and work capacity. So the reality of today's modern society and sports medicine, orthopedics, and rehabilitation are no different, is that we have a plethora of information. And we have as much data as we otherwise could hope for. That being said, we need to be selective in what we measure and how we measure it, such that it's actually meaningful and making changes to our outcomes and allowing us to provide better quality of care. So not all tests and measures are created equal. Let's use this as a prime example. Return to sport criteria for range of motion, dorsiflexion passive range of motion greater than 40 degrees. Great. On face value, this is simple, straightforward. We know how to assess it and what the cutoff is. But more importantly, how is that measured is another question in and of itself, and what goes into a particular measurement. So we need our measurements to be reliable. This is consistency over time, consistency across providers, and across patients and or clients. We need it to be valid. We need to know that the measures that values that we're getting are accurate or at least correlated with the gold standard. For not always are the gold standards clinically friendly and clinically applicable within our settings. What is the standard error of measure? If we get fluctuations from one time point to the next, is this actual true meaningful change? Or is this within the measurement error of the assessment in and of itself? What is the minimal detectable change? what change can we actually detect as far as the smallest increment, and what if that change is actually clinically meaningful? And then what is the normative data? How do we interpret the results? And so these 5 components are critically important as we go through each of the different assessments today. And though some of this information will be provided during the live presentation, I've incorporated each of these components to the best of my ability within the handout that is available to you on the APTA website. If indeed all tests and measures are not created equal, then what is our filtering process to determine whether we should be using an assessment or not? Certainly you could take me on face value and create a carbon copy of this workflow that we are presenting with this algorithm, but the reality of the situation is that it's likely that you're also going to have other unique assessments that you incorporate that are either individual to you, specific to your patients, or to your clinical practice setting. And in hopes of helping you to kind of decide what tests and measures should be incorporated, and to give you some insights as to the filtering process that I've used in coming to the conclusions of the different assessments that I'll present today. I want to also help you as the audience members kind of think through whether a test should be incorporated or not. So do we know what the physical quality of the test measures? Like, what is the physical construct? And do we know what metrics of that construct are of unique importance? We'll use a primary example of a counter movement jump on a force plate. For instance, there is a whole host of different numerical metrics that could be otherwise taken up based off that single assessment. What of those metrics are most important and can be discriminatory against the healthy control versus your injured population, and if any of those metrics are predictive of future injury risk? Does the test have sufficient construct validity and reliability? Do you know how to run the test and interpret the results of the test that you get? And can you do at least 2 of the following? Can you monitor your athlete's progress? Can you prescribe interventions based upon that? And can you rank order the individual based off the results that you get? If yes to all 5 questions, then by all means use the test. But if you're equivocal on any of them, then we need to either consider not using the test, for instance, if there was poor validity or reliability, or perhaps you're unsure of how to run the test or adequately interpret the results. Well, in that case, educate yourself and, again, reconsider utilization of the test in the future. So beyond even just determining which assessments we should be doing, we also need to be vigilant about what metrics and constructs we're measuring. For what gets measured gets managed is a common slogan that has been utilized not only in business, in sports medicine, in healthcare in general. And it's been touted for decades previously. That being said, V.F. Ridgway, who is an academic associate with the Graduate School of Business and Public Administration at Cornell University, who authored this wonderful paper in 1956 that's titled Dysfunctional Consequences of Performance Measurements. And his argument can be summarized with the following statement: what gets measured gets managed, even when it's pointless to measure and manage it, and even if it harms the purpose of the provider to do so. Thus, we need to continue to be vigilant not only on the selection of our assessments, but what constructs and what metrics we are actually measuring, and whether that's meaningful for the determination of monitoring, prescription, rank order, and return to sport/activity decision making. And with the assessments and the metrics that I present today, I'm hoping to enhance your ability to do so. So in order to help us to measure what matters, V.F. Ridgway offers us some key principles to live by and to measure by. We need to understand the context and the objective. That is to say, we need to understand the specific demands of the patient and or athlete or client that we're working with. We need to have a relative understanding of the important KPIs. I also like to term it KFIs, the key functional indicators to those demands that they have to undergo. Identify predictable KFI deficits based on their specific diagnosis and condition. For an instance, an individual that has an ankle fracture versus the individual that has a lateral ankle, a functional ankle instability versus the Achilles rupture, they all are going to have predictable deficits, but their key functional indicator deficits are going to be much different from one to the next, and where the emphasis of rehab lies, and thus the emphasis of your assessment lies, is going to need to be individualized to the patient as well as to the condition. We need to avoid single criterion measures. That is to say, we need to use multiple criteria judiciously, employ multiple performance metrics that capture all critical aspects of the condition and the physical demands. And then we need to develop composite measures that are clearly weighting the different variables there within appropriately. And we'll talk about certain examples of this as we move forward today. And then we also need to regularly review and adapt metrics. The return to sport process is multifactorial. And we're only really talking about, as Matt alluded to earlier in the part one of this presentation, there's more than just the physical constraints that determine someone's readiness for the return to sport and for the return to sport clearance. But when we look just within the physical domain of the individual or the organism specifically, we're looking at their patient-reported outcomes, their subjective report of how they function, as well as their psychological readiness, their physical exam, their range of motion, their postural control, muscle performance, and eventually to their higher level performance of physical performance tests that are reassessing the foot and ankle's integration and capacity at which it integrates back into the kinetic chain. Okay, so without further ado, let's get into our first domain, ankle and foot range of motion. All right, so when measuring the range of motion of the foot and ankle, there have been documented predictable faults that lead to error measurement. And so it's important to identify what those are, such that we can talk about some pro tips on how to make sure that we're getting accurate measurements of the foot and the ankle. So when using a goniometer or any other related tool for measuring the foot and ankle, we need to avoid these common errors by following these pro tips. First, proper positioning of the patient in the goniometer, ensuring that the patient is in a consistent and relaxed position, seated, supine, or with the foot supported. Ensuring that we have accurate alignment, of course, of the goniometer in our anatomical landmarks. Failure to isolate the motion to the particular joint. The example given is the MTP joint. Unintentional movement of other joints such as the ankle and or midfoot can influence the measure in a negative fashion. Thus, we're measuring something else than what we intend to measure. We need to stabilize the foot in the joints above and below if we're talking about the ankle. Inconsistency in the measuring technique, so we need to be standardized and have a standard operating procedure in the way that we assess. It's okay for treatments to be individualized and for there to be creativity within that. Yet when we come back to measurement, in my opinion, it really should be a little bit more black and white and a little bit more cookie cutter in the way that we execute our assessments. Thus, if we do get fluctuations within our objective metrics, we can determine that truly to be based upon the measure at hand and the construct and the patient specifically, rather than due to the variability within our practice, and not accounting for the patient comfort and or pathology. An example of this would be hallux rigidus or pain. The range of motion might be limited really more to either fear or the symptoms that are elicited based upon the movement. We need to know the limitations of our measures. Prime example, The clinical measurements with a goniometer typically underestimate the hallux dorsiflexion as compared to radiographs, and thus the clinician needs to know that with the understanding that their range of motion values it may be underestimating what truly the true actual numerical value and what the hallux can actually do, and interpret the results accordingly. And so by avoiding these errors and employing the consistency and the standard operating procedure and techniques, we as clinicians can improve the accuracy of our hallux as well as the foot and the ankle measurements. Okay, going back to our conversation about measuring what matters. Our clinical foot measure the foot posture and mobility associated with foot kinematics. There are so many different joints in the foot and ankle. Do we need to measure them all, and do they all have the same weight appropriate to them? The spoiler alert here is no. So the degree of variance in peak and range of motion kinematics and the variables are independently explained by a multitude of different factors. You can see that the foot posture index has the most predictor, is the most significant predictor across the greatest number of kinematic variables around the foot and the ankle when walking or during dynamic movements. We can use walking as a surrogate measure of that. And yet, even though it is a significant predictor across all kinematic variables, it is still relatively low at maximal 22% predictability. And then the conclusion that the authors come to is that the foot posture measures can explain only a small amount of variation in foot kinematics, particularly the FPI, were most strongly associated with the foot kinematics versus foot mobility measures. These findings suggest that the foot kinematics cannot be accurately inferred from the clinical observation of the foot posture alone. So we take this information into account, and I present it up front again because it helps us to think through measuring what matters most, and thus, yeah, there are very reliable and valid metrics of looking at static foot posturing, and yet we just need to recognize that if we so choose to incorporate that within our arsenal of assessments and within our SOP, well then that's fine. Yet we also need to recognize the limitations and the predictability or low predictability that some of these static measurements have. So when we're talking about the foot and ankle motion, as I alluded to earlier, when we're talking about the most likely mistakes that can be had, there are multiple planes of movement around the foot and the ankle, and thus there are multiple different measures and different terminology, right? So we can kind of organize it into the fundamental movements and then the applied movements. The fundamental movements occur around the three primary axes of the transverse, sagittal, and coronal axis, respectively. And then we have the plantar flexion and dorsiflexion within the medial longitudinal axis. We have the vertical axis, which gives us abduction and adduction. And then we have the AP axis in the frontal plane that gives us our inversion and eversion. And just so we are using these terms synonymously, I present this here. I recognize that this is review for many of you in the audience today. And then we have our applied movements, which is the pronation and the supination, which occurs across the oblique axis of the foot, which is these pronation and supination are a combination of three of the different movements that occur within the fundamental, occur under the fundamental movements and in the primary axes. And so we'll take this the purpose in presenting this is one, so that we're all on the same page as to the planes of movement that the range of motions of the foot and ankle occur in, and what the terminology is when we're talking about inversion, eversion, abduction, adduction, so on and so forth. So, furthermore, we can break it down into open kinetic chain assessment and closed kinetic chain assessment. For the open kinetic chain assessment, we can break it down into the forefoot, midfoot, and rear foot. And synonymous with that, we can do the same with the closed kinetic chain. For the forefoot, we'll break it down into the hallux, the first ray, and the forefoot. Midfoot, you can look at the cuboid, the navicular, and the forefoot locking mechanism. Rear foot, inversion, eversion, plantar flexion, dorsiflexion, both knee extended and flexed. The Achilles resting angle we'll talk about as well. When we look at the closed kinetic chain range of motion, there's the hallux, active and passive, the forefoot, inversion and eversion, the medial longitudinal arch, the navicular height, and then the rear foot comparable to what we saw in the rear foot in the open kinetic chain. And so these measures are consistently measured in supine. These measured predominantly in prone. And then we have a couple of the closed kinetic chain assessments that are done measured dynamically. So let us start with the forefoot open kinetic chain. Okay, so here's a table of the supine forefoot open kinetic chain assessments and the different motions, as well as the criteria that is recommended for each motion in order to determine someone's clearance for return to activity and to ensure that they are ready to move forward within the progression of rehab. So I'm going to use the same framework moving forward across the different portions and the different ranges of motion. So I just want to take a moment to kind of orient you to the framework. So in the first column, it's going to be the position as well as the portion of the foot that we'll be measuring, the motion or motions, the measurement method, the criteria, and then the comparison criteria beyond just the independent criteria or individual criteria in isolation. For instance, let's take the first ray. The first ray should be able to plantar flex and dorsiflex 5 millimeters in each direction, but the comparison criteria would be that we need it to be adequate to normative data for that particular condition. For instance, if someone has a forefoot fusion or has a pinning of the first ray, we may not expect that same mobility. Vice versa, someone's mobility of their foot natively may actually be different than what it is post injury. And thus we compare it side to side. And so it allows for individuality within that particular person as a comparison as well. Okay, so first ray. We would expect the first ray to be able to plantar flex and dorsiflex appropriately by 5 millimeters. You can see that this is the inter-rater reliability and the test-retest reliability is somewhat in question. You can enhance your quality or your accuracy and your reliability within of this assessment by being more consistent, as well as the more often that you actually measure it and assess it. And there's actually tools that that you can implement to assist with the amplitude of displacement in the plantar flexion and dorsiflexion motion, respectively. Hallux extension and flexion, we expect 70 degrees of hallux extension. We need the hallux to flex up to 45 degrees, so as an amplitude of approximately 105 or 115. Inversion and eversion of the forefoot. This is more of a supination and pronation motion of the forefoot. You can use an electronic goniometer and or phone along the broad base of the metatarsal pads to look at this inversion and eversion. Should be an inversion of approximately 45 to 60 degrees and an eversion or pronation of 15 to 30. Again, these are relatively broad ranges, but that being said, that's going to be dependent upon the person's age, their demographic, the condition at hand, and this is where you can get a baseline by looking at the other limb with the presumption that that is a healthy limb or healthy comparator. And then the fourth one here is accessory mobility, which is assessed manually. The reliability here is in question. You can see the criteria as well as that clinician expertise is needed in order for the determination of whether it's sufficient or adequate for the physical demands of the patient in question, as well as the mobility and the rigidity of their foot on the whole. So of the 4 assessments. The ones that can be quantified are the first 3. And then our comparison is 90% limb symmetry index or indices from one limb to the next. Okay, so why would we care about the first ray mobility? So I think it's important to highlight that to give justification for why I'm endorsing measuring what we're said to be measuring. So the first ray hypomobility is a risk factor for hallux valgus, central metatarsa stress fractures, metatarsalgia, hammer toe, acquired flat foot deformities, tibialis posterior dysfunction. Moreover, it is the keystone of the medial longitudinal arch, which is a critical functional architecture of the foot, not only statically but also dynamically. This allows for execution of functional movements, and even mild hallux dysfunction has been associated with walking mobility impairments, balance impairments, postural stability, and fear of falls. Okay, so let's go ahead and assess the rear foot. This is going to be in the prone position, still under the umbrella of open kinetic chain. Okay, so the criteria here, it's going to be looking at the inversion and eversion. Again, you can utilize a goniometer for this. There are applications out there on your smartphone and or mobile device that will also help you with this. You want a ratio of about 2 to 1. Typically, it's going to be about 20 degrees of inversion and 10 degrees of eversion. The plantar flexion is going to be 50 degrees. However, this can be quite variable between 20 and 65 degrees with a meaningful detectable change of 13 degrees. The dorsiflexion is going to be 20 degrees or more with the knee extended. Again, this can vary anywhere between 10 and 25. The Achilles tendon resting angle, which is going to be most pertinent for your Achilles tendon rupture, and it's a surrogate measure for how much tension or stiffness exists within the triceps surae, particularly within the tendon itself at rest. In an uninjured tendon, you're going to have anywhere between plus or minus 7 degrees from 43, and it can be highly variable based off someone's connective tissue, how much stiffness that they have, and that you can see the normal arc between 26 and 61 with an average or mean of 50. A ruptured tendon can be at 55 degrees plus or minus 8, and a repaired is going to be at 37. So the larger angle here is going to be an indication that the ankle is going to be more in a closer to neutral position, because this is the angle that in question that we're looking at. So when it says uninjured at 43, but then your ruptured is going to be at 55, they're going to be more dorsiflexed. And then with the repair, you can see that they're quite stiff immediately after repair, where they'll be closer to 37 plus or minus 9. And then with your dorsiflexion, knee flexed position, you're going to be looking at 30 degrees versus the 20 with their knee extended. So let's talk about the clinical significance of ankle dorsiflexion. So an increase in ankle dorsiflexion passive range of motion was associated with an increased knee flexion displacement and decreased ground reaction force during landing, meaning you absorb the force and the ground better, which may be associated with decreased ACL loading and has also been associated, therefore, with a decrease in ACL risk. The clinical measures of dorsiflexion may be helpful in identifying individuals with who are at risk or increased risk for ACL injury or lower extremity injury. As you can see, a decrease in dorsiflexion range of motion is associated with an increased ankle and overall lower extremity injury risk. Prior sequelae of a lower extremity injury, particularly around the foot and the ankle, is associated with a decrease in dorsiflexion range of motion. That's solely on us to be able to not only educate, but also to prescribe effective interventions and to appropriately monitor and determine someone's readiness to return to their activity after that restoration of that range of motion. Varying degrees of altered kinematics and dynamics at the pelvis, hip, knee, and foot, so all the way up the kinetic chain during walking and jogging, have been associated with a decreased dorsiflexion range of motion. And then it's also shown that there's a decrease in the body's ability to propel itself forward effectively in walking and jogging. And this leads to a decrease in performance, and has also been associated, as we've seen previously with the other citations, an increase in injury risk. So the mechanism at play there is that the plantar flexors are dorsiflexion biased. So if you have limited dorsiflexion, be it at the joint level or due to soft tissue restrictions, then you don't necessarily reach your angle of peak torque with your plantar flexors, reducing your forward propulsion, be it in walking or jogging. Okay, so how are you going to measure it? So again, I noted that all these measurements and assessments are going to be performed in prone. I'm a big proponent of using modern technology because of its accuracy, not only reliability, but also the validity that has been shown, specifically with the gyroscope and the different applications that utilize that within the smartphone and mobile devices. So the patient's prone, their knee is extended to 0 degrees. You can see the opposite leg is in a figure 4 position, such that the assessment limb is going to be rotated, such that the long axis of the leg is going to be more perpendicular. It allows for more of a pure dorsiflexion range of motion versus going off at an oblique axis into pronation. And then with the measurement tool, as I mentioned, you want the phone flush along the calcaneus. So it's important to differentiate between whether you're capturing forefoot plantar flexion or rear foot plantar flexion. Right now we are focused on the rear foot. And so consistently, I'm going to put the corner of the phone, as you can see it, right up to the crux of the head of the 5th metatarsal, such that I'm going to capture more of the calcaneus plantar flexion, or excuse me, dorsiflexion and motion rather than the forefoot, which is the forefoot typically being a bit more mobile than the hind foot. And going into, there's going to be an inflection point into into dorsiflexion. The reliability here, as I mentioned, not only within a single clinician, but across clinicians and from one time point to the next, excellent. When we look at the knee flex position, again, the patient's prone with the knee flex. You're going to standardize the vertical tibial position again. So I usually just use the phone right up against their fibula and zero it out to a plumb line, which is consistent with the absolute vertical. The phone, once again, is flush with the calcaneus. I do use the functionality of the clinometer app that gives a auditory sound of a beep and then goes through it, so it zeroes it at the once the reading of the phone is at the absolute horizontal, and then I measure it from there. Once again, consistently good and excellent reliability, as shown also with the knee extended position. Okay, so let's talk about the clinical significance of the Achilles tendon resting angle. Post repair is associated with a decrease in heel height and a decreased total workload on a single leg calf raise test. Also, a decrease in plantar flexion strength post Achilles tendon repair is associated with the lengthening of the tendon during the healing phase. The ATR is strongly associated with the shear modulus on ultrasound. What does that mean? It means that it's associated with how stiff the tendon also is. The stiffer the tendon, really the more robust the repair, the more elastic tension and potential energy and elastic storage capacity that the tendon is going to have, and then be able to release it to assist with forward horizontal and vertical propulsion. The tendon elongation leads to functional impairments. This is significant and oftentimes is touted as one of the complications post Achilles tendon repair that can be devastating depending on the level of competition of the athlete or patient. The end range plantar flexion weakness is very difficult, and that's sometimes not able to restore if there's an elongation of the tendon. Changes in the triceps surae activity has also been associated with this. Altered running and jumping mechanics because of the altered length tension relationship of the muscle and the myotendinous unit. And then for every 12 degrees of an increase in the dorsiflexion angle, that's associated with a greater than 1 centimeter tendon elongation. So it's an important metric to measure not only from a not only from a anatomical standpoint as to the resiliency of the repair and the stiffness of the tendon, but also functionally. So what does it look like? I gave the brief image previously when we were looking at the criteria. So it's going to look like this. You're going to have the long axis of the goni along the long axis of the fibula or the lower shank. The fulcrum is going to be just below or just at the tip of the lateral malleolus, and then the long axis of the goniometer, or the distal long axis, that is going to be running along the fifth metatarsal, or just the head there of the pinky. And what you'll see is that a positive ATR is shown there post-injury, where the red line indicates where the foot exists, and whereas the black line is where it natively sat. The post-repair, there's an additional stiffening, right? We gave the specific numerical values that on average it's around 37 degrees. That changes from that. Again, that's off of the absolute vertical. And then post-rehab, depending on the acceleration and how quickly someone weight bears and how well they adhere to the weight-bearing precautions, then we see a gradual residual decline in that angle, or in the elongation, even though there was that initial post-repair increase in stiffness and shortening of the tendon. So you want to do everything you possibly can to be able to preserve that. Once again, similar to the other ankle motions that we've seen in prone in the open kinetic chain, excellent reliability. The standard error of measure is pretty darn good. It's 2.4%. That equates to 1.5 to 2.5 degrees. Minimal detectable change is 4.3 degrees, which is about 6%. Also really good, as indicated by the coloring of the values there. Green being good. So what does it look like across time? So the ATR across studies consistently demonstrates a significant improvement immediately post-operative, as I mentioned. So you can see in the figure to the right, on the y-axis, you have the ankle angle, 0 being neutral, minus 15 being in the dorsiflexion, and then the 10 degrees being in the plantar flexed position. So the improvement in the ATR between 3 to 12 months suggests that the ATR changes are not associated with the suture absorption. The ATR changes are more associated with the period of mobilization after the splint removal. And we also see that the period of early weight bearing and early mobilization suggests that we need to be reconsideration of the concept of early rehabilitation and how aggressively we're putting weight into the plantar flexors and any tensile loads that may be going through the tendon. It's maybe more advantageous for it to stiffen up and thus allow the modulus to really stiffen and heal prior to going into our weight-bearing progressions. Wedges alone do not prevent the increments in ATR. In the Achilles tendon resting angle, we need to be more judicious and rather than just relying solely on the wedges themselves. And you can see the 4 versus the 6 strand that the 6-strand group does a little slightly better around the 3-month mark, but eventually there is a regression where at 12 months there's no significant difference. Okay, so similar figure to what we saw in the previous slide. So 0 represents relative, that is relative to the other side or the contralateral limb. And then plantar flexion is indicated by the positive numbers on the y-axis scale, and then the dorsiflexion are associated with the negative numbers on the y-axis scale. And then you have time running across the x-axis. The red line indicating the musculotendinous ruptures, whereas the green line indicating the mid-substance ruptures. So what we can see, the take-home story here is that the mid-substance ruptures do a bit worse in regards to the ATRA, and you can see that the tendon elongation in the table shown to the left is that there's 21% 21% of the cohort, of the mid-substance cohort, had an elongation versus the 0% in the musculotendinous ruptures. And this just speaks to again the anatomy as to which portions of the anatomy are most responsible for the passive plantar flexion and the tension on the triceps surae and the Achilles tendon. And it suggests that it's more within the tendon itself rather than at the junction of the musculotendinous unit. And then we can see down at the bottom is that beyond just the preservation of the tendon stiffness and length is that the individuals within this cohort at 6 weeks period of brace protection have little limitation, although they still are challenged with a heel raise at 1 year. But as we'll see in the strength aspect or portion of today's presentation, is that following Achilles tendon rupture, that this can be an ongoing several years, even decades down the line in regards to people's strength deficits. But again, we will talk about the assessment of that and how to interpret it in the next sections coming forward. So I gave a brief introduction on how to actually assess it. That is the Achilles tendon resting angle. I'm going to just go through it step bullet point here and talk about the normative data. So again, they're in prone, their knee is flexed to a plumb line of 90 degrees with the long axis of the lower shank being at the true vertical, and then having the goni set up as shown with the fulcrum at the tip of the lateral malleoli, and then the distal arm of the goniometer going through the the distal end of the 5th metatarsal. You can also utilize a electrical goniometer or even your phone, granted that those values are going to be different than the angle that you capture from the goniometer here, because you would have to line up the phone again, not on the sole or plantar surface of the foot, but rather with a line drawn between the the lateral malleoli and then the distal portion of the 5th metatarsal. So what we see in the studies shown here is that healthy individuals, that there's a wide variance between the different studies. The one outlier, the asterisk, is measured with an electronical goniometer along the 5th metatarsal, and so that would, if you're going to use the phone, then you would use that reference rather than the others, as I mentioned a moment ago. But other than that, if you're using the goniometer, you're going to be seeing that the values of healthy controls are going to be anywhere between, again, 43 all the way up to 52 degrees, plus or minus 6, with a range of 36 to 66. And then post-repair, it's also important to know what to expect, because you may not expect that to be consistent with the healthy. And we can see from the Carmont study in 2015, they've done a nice job of doing serial measurements all the way up through 1 year and how it can change. Again, we saw that graphically previously, but we're hoping that they're going to finally stop changing around the mid 50s, again 55 plus or minus 8 degrees. You can see there in the non-operative group. And then when we look at the operative group, operative repair, they are also within that same ballpark. Yeah, so then when we look at the ankle range of motion for plantar flexion and the knee flex position, once again, the patient's going to be in prone, knee flex to 90. You'll zero the absolute vertical using the phone along the long axis of the lower shank, that is along the fibula. We will see that the phone is going to be flush against the calcaneus with the corner of the phone right at the inflection point of the fifth metatarsal, and that's the kind of the inflection point between the rear foot and the midfoot. And that's going to ensure that you're going to get an accurate measurement of the true rear foot plantar flexion. Certainly you can look at their plantar flexion of their midfoot by simply sliding the phone up, putting the bottom corner of the phone, that is the lower corner, at the same point at where you see it in the figure there. When we look at knee flex versus knee extended, just note that you're going to see different values. So in the extended position, again, the premise that I'm going off of is the anterior tissues, that is the quadricep and the myofascial continuity that runs down the anterior portion of the leg is in a slackened position, allowing them to access a little bit more. If you do it in a knee flex position, again, you may be able to kind of isolate a little bit more to the ankle, but keep in mind that the soft tissues tension may be on play depending on how much tension someone has in the anterior aspect of their fascial lines. And then you can see the normative values and how it changes for each gender and age group over time. Okay, and I stand by what I say in regards to the reliability and the validity of the different applications and leveraging modern technology for your range of motion assessment. So you can see the list on the left-hand portion of the screen, the different applications and that have been utilized in taking someone's foot and ankle range of motion. In the top section, we have gait. Along the x-axis, again, you have minus degrees and plus degrees as far as the difference in regards to the standard reference standard. And what we can see is that really it's to the clinician's discretion as to your tool of choice, because they all show to be well within the acceptable range, particularly for the range of motion. Obviously, you can see the larger standard deviation there in regards to the gait, which is more dynamic and obviously more fluid and a little bit more difficult to capture. But what has been consistently shown, and I know I'm only using dorsiflexion here as an exemplar, but it has also been shown for the other foot and ankle metrics that I had conveyed it with earlier. Okay, so moving right along to the closed kinetic chain assessments. Again, these are going to be weight bearing. Some of them, as you can see by the italics text, as well as the asterisk sign, that these are going to be assessed in more of a dynamic fashion. Okay, so for the medial longitudinal arch, again, you could use a goniometer or a phone. Though this is predominantly more of a fixed metric, it's worth noting what arch height someone has. We'll talk about the significance of the medial longitudinal arch angle in future slides and in future sections of this presentation. When we look at standing rotation, this is to get a gross idea in regards to someone's inversion and eversion, similar to what we measured on the table in the open kinetic chain format. Then we have the double limb squat, and this is pronation and resupination. This is a little bit more of observation and clinical expertise, and so it's less quantifiable. That being said, it should look relatively symmetrical, and it may just be a gross indicator that further in-depth assessment, be it manual assessment or otherwise, is still necessary within one of the or two of the axes of the foot and ankle. Modified spring ankle navicular height. This is a modified assessment of the navicular height and how well someone can support their medial arch. I spoke about previously the importance of looking at the foot orientation, not passively or statically, but rather how it moves dynamically. And this will be presented, this specific assessment, though it can fall under your foot range of motion in a closed kinetic chain area. I'm going to preserve this for more of the motor coordination component within the muscle performance aspect of the presentation, because that's where it falls for my in my clinical practice, but by all means, you wouldn't be amiss to put it here. And then you can see the reliability is excellent in regards to the MLLA, at least between raters and across raters. There is a little bit larger an angle between 2.8 and 7.5 degrees, but as a percentage, that's less than 1% of what would be the actual angle. So again, that is considered to be quite good in regards to the reliability. And then clinical observation reliability. What we can see there is that the test-retest is good, and then the pronation-supination reliability is also excellent. Okay, so here's the closed kinetic chain rear foot and forefoot mobility assessment for inversion and eversion. You can see as someone supinates and pronates that they go through tibia internal and external rotation respectively, is that you're going to get a reciprocal motion at the rear foot as well as at the countering motion at the forefoot. So it would look something like this. You can see it in live time in the video, and then to accentuate the different movement patterns of the forefoot into pronation and supination, you can see that in the small schematic to the right. And then if you're still in question, if you have the person do a mini squat, you can see that by squatting, that puts a little bit more tension on the system and then can further exaggerate the pronation and the supination. And then I usually have them turn around and they will do it the same in the from the rear foot. So you can get an appreciation as to whether someone's able to get into the reciprocal and symmetrical inversion and eversion that you would expect based off what your findings were on the table during the open kinetic chain assessment. So this is really what you're looking at, and again, I appreciate that it's just an animation, but it's helpful to convey. So as someone goes into a rotation of their tibia, you're going to expect the rear foot to pronate and supinate respectively. So as they go into an external rotation of their tibia, they're going to go into supination, and as they go into internal rotation of their tibia, they're going to go into pronation. And you can see that shown here. So on the x-axis, you have the amount of tibial rotation that is induced on the lower leg, and then on the y-axis, you have the degrees of pronation and supination respectively, and how these two motions are coupled. So beyond just I recognize that the assessment itself is more abstract and observational and qualitative compared to the other ones I've presented. There is a strong biomechanical association with these coupled movements. And again, even if you use it as a confirmation that the range of motion that you measured in your open kinetic chain on the table, that they're able to access that in itself is valuable. And I also use it as an additional check of myself to ensure that the feet in the both forefoot and at the hind foot are looking similar and reacting the same with these more proximal rotary movements, and it gives me just cause to go back and onto the table or a more granular assessment if and when needed when I see any rigidity or gross asymmetries. Okay, so why are we going to look at the longitudinal arch? As I mentioned, it does have kind of more of an anatomical fixed nature to it, but it's been reported to have a high degree of reliability and to be predictive of dynamic foot postures. And so it's highly predictive of the dynamic foot posture during walking and running. Specifically, it can explain 85% of the LLA during the mid stance during walking and mid support during running. Less than 40 degrees of LLA cutoff values have been associated with medial tibial stress syndrome. It is a unique cohort of folk dancers, yet all the same, it does suggest that a more rigid foot, a lower longitudinal arch angle, which would be essentially a more stiffened foot, may be associated with higher shock absorption higher up the chain. So the measurement looks like this. Whether you want to actually measure it with your goniometer or take a snapshot. I know that there are several phones these days and applications, once again, where you can draw in the angles, especially if you put the markers on the person's foot preemptively. So you look at it seated, double leg stance, single leg stance, with the phone or with your goniometer. The reliability is excellent with the test retest and with the not only within the rater, across raters, but with the test retest as well. And you can see the actual angle that you're going to be measuring is shown there with the different points of interest being the first metatarsal head, the navicular tuberosity, and then the medial malleoli. Okay, moving right along to the closed kinetic chain. So we're going to be looking at the hallux active and passive range of motion, as well as the rear foot plantar flexion and dorsiflexion. Again, knee extended and knee flexed. This is the closed kinetic chain has been kind of dichotomized into two parts, one being dynamic and one being more static. All right, so looking at the forefoot first, we'll look at the hallux passive range of motion. Whether you want to use a goniometer or the phone is fine. I will say that the passive range of motion here is quite extensive at 70 degrees would be the normative data. The active range of motion would be 65 to 70 degrees. At the very least, your active range of motion to passive range of motion should be 80%. So if you're expecting, say someone's got 70 degrees of extension, then they should be around 56 degrees of being able to actively access that. For their dorsiflexion, knee extended in a stride stance, it should be about 24 degrees plus or minus 6. You can also use this assessment that is suggested by the SFMA with the forefoot clearing test, where you have them stand in tandem right up against the wall, and then the hind foot should be able to completely clear the forefoot of the hind limb should be able to clear the floor completely. And then with the knee flex position, you're looking for at least 40 degrees. You can see that the knee flexion angle indicated there needs to be at least 20 in order for there to be a sufficient slack on the posterior chain to make meaningful differences from that of the extended knee position. Further knee flexion has shown both in the open kinetic chain as well as closed kinetic chain not to make a significant difference in the resultant tibial anterior angle. So as long as it's 20 degrees, you're good. We can see that plantar flexion heel height should be 8 centimeters. Or the foot angle should be at least 30 degrees off of the floor, and that with a fulcrum of the MTP joint of the hallux. And then you can see the reliability both for the assessments shown, hallux extension as well as dorsiflexion, that the reliability is good to excellent, standard error of measure, both within appropriate ranges. You can see the criterion for the hallux extension, that the clinical assessment undershoots it slightly at 13 degrees relative to the x-ray, whereas with the dorsiflexion, it's pretty consistent with the digital inclinometer as well as the tape measure, both within an acceptable error measurement. We've emphasized the importance that it's not only what we measure, but how we measure it. And I think this is a prime study that really was influential on my practice, and perhaps I can make it influential on yours as well. So we're looking at the effects of subtalar joint position on dorsiflexion of the ankle, that is the rear foot, versus the midfoot and forefoot during gastrocnemius stretching. That is consistent with the closed kinetic chain dorsiflexion stretch that we had promoted in the previous slide. So it's the study design was repeated measures. They used university recreational running clubs. Average age was 31, with a bias more towards females. The cohort was those individuals that had limited dorsiflexion, current or recent lower extremity chronic condition. And the instrumentation was a Vicon motion analysis, 7-camera system, as well as a force plate. And then the outcomes that they took were the dorsiflexion at the midfoot and at the rear foot, and also the ground reaction forces. And so on the y-axis in the graph that you see in the figure here, that you have your midfoot and forefoot dorsiflexion in degrees, and then you have the pronation and the supination respectively. And you can see the left and the right foot, and what the stretch, and that is of the stretching position. So you can see significantly that the right foot here had significantly more midfoot and forefoot dorsiflexion degrees. So let's look at the next slide to understand the significance of this. So the closed kinetic chain dorsiflexion performed with the subtalar joint position in subtalar neutral supination significantly decreased the dorsiflexion contributions of the midfoot and forefoot versus like the pronated position, and that is reflected in the laterality. So the left limbs here were performed in a subtalar neutral position by giving a small domed piece of foam to support the arch. The clinician, this means that we as clinicians may want to consider the subtalar joint position during our gastrocnemius stretching, as well as during our assessment, in order to limit the recruitment of dorsiflexion motion from the forefoot and ensuring that we're really getting true talocrural ankle dorsiflexion. Okay, a similar study in 2009. So you can see the setup there in the schematic. So the individual is in a lunge position against the wall. They're looking at the dorsiflexion of the hind foot, and the camera system is shown. You can see the vantage point from the camera's viewpoint, looking at the rear foot pronation versus I guess it's pronation or more pronation. And the individual with the less pronation, you can see just peeking out of the medial aspect of the foot is that they have a medial arch support during the standing wall stretch, comparable to what was shown in the previous study. In the neutral foot type cohort, resting calcaneal stance position, plus or minus 2 degrees, and a navicular drop of 5 to 9 millimeters, whereas the pes planus foot type cohort, the resting calcaneal stance position was greater than plus or minus 4 degrees, and their navicular drop was greater than 13 millimeters. And so this is the medial arch support wedge that they used. And what did they find? So again, they have 2 different cohorts. One has more of a flat foot, one has more of a neutral foot. Regardless of that, so let's just orient you to the y-axis. So you're looking at the musculotendinous junction displacement in millimeters. So the less displacement, the better, the more stable the medial arch is. I'm sorry, this is looking at the displacement of the gastrocnemius musculotendinous junction. So it suggests like how much excursion is occurring at the musculotendinous junction. And you can see that the neutral foot and the pes planus foot respectively, and that those without the medial arch again had less excursion. And then if we look at the ankle dorsiflexion range of motion, that was actually different, where once again you can see that we actually get more range of motion out of the ankle when we have adequate support with the medial arch support. And then the navicular drop accordingly. So you're looking at the navicular drop height, and once again we get a better stabilization of the navicular drop, particularly in the pes planus foot, when there's a medial arch support. So the take-home message here is that regardless of your foot type, but if you have a more flat arch support, or your patient does, then the more important it is to support your medial arch such that your dorsiflexion actually goes through the the hind foot rather than through your navicular or midfoot. And then the musculotendinous junction displacement, again, it can occur not only just because of the dorsiflexion, but also because of the navicular drop and the pronation that occurs there. Okay, so I alluded to when we were looking at the table the importance of the knee flexion position and how that influenced the ankle dorsiflexion. So this was a repeated study, or repeated measure study. It was healthy individuals, 20 of them, split evenly 10 and 10 for females and males of adult individuals. They had blinded assessors. Standard goniometer was used. You can see that they did a closed kinetic chain ankle dorsiflexion measurement of knee flexion angle at 0, 20, 30, 45, 60, 70, and in a lunge position, and they put the splint on the limb to ensure that the knee was flexed to that specific angle. So what did they find? So they looked at ankle dorsiflexion and its influence relative to the knee position. So in the figure on the y-axis, you have the ankle dorsiflexion angle, and then running along the x-axis, you have the different parameters of the knee flexion angle. And you can see that really once the knee flexed to 20 degrees and beyond, that the dorsiflexion angle really didn't change. And this gives us credence that during the weight-bearing ankle dorsiflexion range of motion, that as long as the knee is flexed to 20 degrees, that the ankle angle may not significantly change there beyond. And this was shown both in the non-weight bearing and in the weight bearing positions. I had endorsed earlier within the lecture that I flex it up in the open kinetic chain dorsiflexion assessment with the knee flexed. I bend the knee to 90 degrees. Why do I do that? Because it ensures that I can be very consistent and replicate my assessment. If I flex the knee to 70 degrees, I may not know exactly where that 70 degrees is or that 45 degrees is. But if I consistently flex them to 90 degrees and normalize the long axis of their lower shank to 90 degrees, well then I can be very consistent and replicate that very easily and time over time for monitoring their dorsiflexion in that position. But I recognize that you only really need to flex the knee to 20 degrees, be it weight bearing or non-weight bearing. So how do you perform it? So you're going to put the person in a lunge position. They're going to be half kneeling, should be barefoot. Again, we spoke about the importance of the subtalar neutrality and having a medial arch support. You can use a small towel roll if needed. You're going to use a goniometer, either your standard plastic one, or I would endorse and encourage you to shift to modern technology with your mobile device. Your starting ankle angle is going to be 0 degrees. You can see that the reliability, the standard error of measurement, and the meaningful asymmetry values are shown there. You're going to put the corner of the phone on the tibial tuberosity. Though it has been described that you can measure the distance between the toe relative to the wall, that's fine. I typically so choose to look at the tibial angle rather than the distance. Sometimes I capture both just because I like to have a cluster of assessments to double check it. And, that goes back to our principle of not hanging our hat on any one single measurement, but having a judicious means of multiple measurements that capture a comprehensive means of a particular construct or different physical capacities. All right, so we want at least 40 degrees. Those individuals that have less than 34 degrees have a 5 times increased risk of a lower lateral ankle sprain within a given playing season. If you're looking at the distance, that is the tibia and foot length may be confounding variables here. Because if someone has a really long tibia, then that may influence the distance that they get from the wall, but your metrics here, again, it is kind of gender specific, between 12 and 13 for males and 13 and right up to 15 for females. But greater than 10 centimeters would be ideal. All right, closed kinetic chain dorsiflexion pro tips, because this is often, I consistently see it done. You're going to want to keep the pelvis and the subtalar joint neutral, and you're going to want to keep that hind heel down. Because people can go into rotation around their pelvis and or the tibia in order to be able to achieve a greater range of motion. Typically, I also see this is where they will either go into knee varus or a valgus position and look to get further range of motion. But really, you want to ensure that you get the midline of their patella through the long axis of their foot, be it at their third ray or the web space of their second and third toes. I've also endorsed the utilization of my jump lab, if you want to use that. That allows for a very quick assessment you can see my mobility or my range of motion, where you put the phone right at the tibial tuberosity as shown, and it will cue you for the left and the right respectively, and then it will also keep that data for you for your different patients if you so choose. So just another way beyond just taking it off your inclinometer on your phone. Okay, so clinical significance and summary. So we talked about the open kinetic chain and closed kinetic chain. So here are the values. So your hallux, it should plantar flex 45 and 70 degrees respectively for plantar flexion and dorsiflexion in the open kinetic chain. We want that first ray to move by 5 millimeters. Inversion and eversion should be 45 and 15 degrees respectively, with the forefoot. When we look at the rear foot, inversion to eversion is going to be a 2 to 1. Plantar flexion is going to be 50 degrees. The knee flex versus extended position can be influential in this number. We looked at the dorsiflexion extension. A dorsiflexion with a knee extension, 20 degrees and then 30 degrees respectively with the knee flexed, and how flexed, over 20 degrees. We talked about the ankle tendon, the Achilles tendon resting angle in ruptured as well as in repaired tendons. We spoke about the forefoot. We spoke about the relationship between active and passive range of motion, that you should be able to access 80% of your passive with your active extension. When we looked at the medial longitudinal arch, we gave that one cut point of 140, but we know that the norms would fluctuate between 131 and 152. Navicular drop height we will talk about in subsequent sections of this lecture. And then finally, for the closed kinetic chain, you're looking for 30 degrees. If you're looking heel height, you're going to look for a minimum of 8 centimeters. We'll talk about this more during the single leg calf raise and heel height. Looking at dorsiflexion knee extension 24, and then knee flexion at 40 degrees for each of the positions respectively. And then inversion and eversion comparable to what you saw on the table, but now in a weight-bearing dynamic rotation type format. So that is the summary. And if you have any questions, concerns, feel free to leave them below. I've included the references as well as the abbreviations, as you can see in the slide. All right. Thanks so much.